more here is to share my experience, what I came across the complications, how we dealt, and then if somebody needs to add anything, want to add anything, they can add later on. So whenever I counsel a patient or any talk, basically what we say, ECMO is the last option when you try exhausting all your conventional, because it's not without complications. Treatment, the ECMO treatment you're proposing. It's not an exception. Complication, as you maybe think, complication will happen to every patient on ECMO, and small or big one. But it's a prompt recognition, management is essential, and anticipation preparation is most important. And for that, one needs to have an understanding of how the physiology works and how the circuit works, and training and hands-on experience like this will help you to anticipate and tackle these problems. So if you want to categorize the complications, they can categorize as patient-related predominantly or mission-related. So patient-related, these patients are sickest of sick, ICU patients, or all complications which normal ICU patient would have, and they're prone for those things. In terms of the ECMO specific, would be the bleeding, which is the most common complication, and the mechanical complications like end of the day is a mission, so it's prone for failures. So we need to constantly check for those things on a regular basis. So again, the patient-related complications, you can divide it depending on the system model. And the common things which will happen is a systemic inflammatory response. Because when blood comes in contact with the non-endothelial surface, so the complement system gets activated, and all the patients who go on ECMO, they develop systemic inflammatory response syndrome. And if somebody has seen the ECMO patient, and the first 24 hours, they seem to be more swollen, more anasaka, and the X-ray gets worse in the first 24 hours on going on ECMO. It is mainly because they're going to capillary leak because of the surge response. And what my experience, what I've seen is that the more sick is the patient, more surge response they're going to have. If somebody is on a very high pressures of ventilation, or very high NO2, very sick, they tend to have more surge response. But surge response in relation to ECMO circuit is usually transient, and they tend to respond within 48 hours. If something is getting prolonged beyond that, then that means probably some infection is there, which is contributing to that. And the bleeding is the commonest complication on ECMO. And there's a separate talk how to deal with bleeding. We'll touch on 3 points here. The commonest sites of bleeding is the cannulation site. So where you put the cannula, or if you put it surgically, open it and put it, that's another source of bleeding. And the bleeding can be anywhere in the body. So you need to be very watchful of all these things. And if the bleeding is because of heparinization, then you need to, that's where you're monitoring the heparin effect is very crucial, and titrate the doses as per the requirement. If it is anywhere superficially, like cannulation site, the compression or pressure sutures will help. If somebody like this, open chest, bleeding is a major issue, major issue. It's like patient is on open it with chest open and put central cannulation. So any surgical site, thorough cauterization and ligation and bleeding points if you can identify, and judicious use of platelets and fresh frozen plasma to correct the coagulation defects if you have any, and amical can be used in those situations. GI hemorrhage is because of some stress ulcers, it can be common. If it's a significant thing, then oxidative induction is useful. I want to share one of my experience here. So last year we had a 50-year-old lady with H1N1 infection on ECMO, and after 10 days of ECMO, she started developing PR bleed, colorectal bleed, to the point it was going into massive hemorrhage and massive transfusion we were giving. So initially we tried with sigmoidoscopy. Colon was filled with the blood, but they couldn't identify the source. And then we went on to do a CT angio, and then finally angiogram, proper angiogram, but still we couldn't identify the bleeding source. And then almost by this time she was 3 or 4 days into the bleeding, and we were giving almost like 6 to 7 units of blood every day and tried to stop the heparin. Nothing was getting controlled. And then finally we had to go back again with a sigmoidoscopy. At that point we identified a bleeding source below the dentate line in anal canal. And when we retrospectively think back, I mean, she was we gave enema to her, and somebody who gave enema, they were not aware of these things and then forced into her forcibly and ruptured one of the arteries in the anal canal, and that caused the hemorrhage. But that almost took whatever improvement we had, we lost that improvement, and it took a long time to get the way we lost the point. So as simple as giving enema can be a complication, so you need to be very careful and aware of these things. So not only us we are doing, we might say just give enema and walk up. The nurses who are there at the bedside, they should be aware of these complications as well. And similarly, it's not only just putting enema, similarly, even trying a chest drain in these patients, it can be a catastrophe if you're not careful enough. One of the dreadful complications in ECMO is intracerebral hemorrhage. And that is one of the contraindications. If something happens on ECMO, then you need to stop ECMO for that reason. And it's commonly seen in neonates, but it can be seen in adult patients as well. One of our patients, we had to withdraw the care mainly because he had intracerebral bleed. So usually seen in neonates, so they're more prone for that. So if you have a problem, you can actually run a ECMO without heparin if the bleeding is an issue for some period of time, but you need to be careful with that. So you need to have a backup plan. What if the circuit clots up? So you need to have a standby circuit or oxygenator in case if trouble occurs. So these things we'll be discussing anyway, the management. And yesterday we discussed about the Novo 7 and reversal of heparin in exceptional situations. So if the bleeding is there, try to find out the reason why the bleeding is there. And if it is a coagulopathy, try to correct the coagulopathy, the platelets or FFP or cryo, and try to maintain a lower ACTs. Or if still all these things fail, stop heparin. If everything fails, then you might need to consider to coming off ECMO sometimes. It's a cell saver. The other complication is hemolysis on ECMO, and it's not immediate complications. We had last year we had a 3-year-old girl with ARDS on ECMO. She was on ECMO for almost 60 days, and almost 45 days and then 50 days on ECMO, she developed this urine, which is a cola-colored urine. And the source, what we could identify was the pump head, which was going on for 24/7 the last 50 days, and it was getting heated up, and there was already some clots in the pump head as well. That was contributing to the hemolysis. Then we had to change the pump head, and that treated the problem, that sorted out the problem. So if you suspect a free hemoglobin in the blood, so you need to be really careful how you send the sample to the lab, because that can be nephrotoxic if free hemoglobin in the blood. So you need to be careful with those things. And the causes could be, as I said, it could be heating of the pump head or the clots in the circuit. And if you have a too smaller cannula or generating too much negative pressure to get the blood, that itself can cause. Or if you're needing a very high pump speed, high revolutions to get the flows, that also can cause hemolysis. So depending on the cause, what it is, you need to go from patient circuit to patient to look for each and every possible reason and try to address those things. With the centrifugal pump and change the pump head, so for that you need to stop the ECMO. So you need to have a plan how we go to stop the ECMO and how we change it. So again, anticipation and preparation. So these better to do these things in the daylight hours when all the people are around. Have your pump head ready and primed, and go on a full ventilation, maybe inotropes and everything ready, and then stop the circuit and go on that, change the pump head. And if you're really careful enough, if the perfusionist is experienced, it doesn't take more than 3 or 4 minutes to change the pump head. And if you have a roller pump which is not used, that's one complication. The hemolysis is more of a complication in roller pump compared to centrifugal pump. And if you have a high pump speed, come down the pump speed where you can, if you can maintain the patient on a low flows. And if you have a smaller size cannula, then maybe having another cannula would be useful to increase the flows. And if you have a clot, then usually it happens in the oxygenator or where you have junctions or connectors in the circuit. That's where they usually tend to have a clots. So you need to address. So whenever you checking the daily circuit, that's one of the things you look for any clots in the circuit. So if you have hemolysis, then because it can cause nephrotoxicity and renal failure, so I need to take care of that. So what we tend to do is alkaline diuresis. So give more fluids and with diuretics and add bicarbonate to the fluids, where you're trying to maintain the urine output at least more than 2 ml per kilo with the urine pH more than 7.4. This would be to protect the kidneys, but you need to address underlying cause depending on the reason. And thrombocytopenia, Sunil has already highlighted. One of the things I think our situations to think about is the infection is a reason. Just to add to Sunil's point, our observation is usually it's a gram-negative infection which is tend to cause thrombocytopenia. And as Sunil mentioned, the study we were doing, the preliminary result, it shows that there may be some more antigen overlap between gram-negative bacteria and platelets. So maybe that may be the reason for thrombocytopenia, but it's just what we're doing a pilot study. Results are not completely out yet, so maybe that's throw some light and maybe more research is needed. But other reasons can be like decreased production because they're very sick patient, and if they're in sepsis or hypoxemia prior to going like all this can suppress the bone marrow. Or if you have a clots in the circuit, that itself can consume the platelets. It's like an ongoing de-icing. So sometimes one of the patients I can at least recollect is thrombocytopenia, whatever we do, we're not getting better. And even though we rule out the infection and other things, once she came off ECMO, thrombocytopenia got better. So that kind of related to ECMO circuit, we should tend to persist for even when you come off ECMO sometimes, but it usually resolves within a few days. So with thrombocytopenia, if the patient is not bleeding, we are okay to allow the platelets to come down to 40 to 50,000. But if you have a bleeding patient, we generally advises to maintain more than 1 lakh of platelets. And neonates, we have a slightly higher threshold to transfer the platelets because there's risk of intracranial bleed. And whenever you're giving any blood products, think about that. Those can cause transfusion-associated lung injury as well. So just for the sake of numbers, don't give platelets or any blood products if not needed, if the patient is clinically stable. Neurological complications, one of the dreadful complications, apart from intracranial bleed, other complications could be they can have seizures, or just because some of the patients, what I've seen is when you initiate the ECMO very late and they have sustained hypoxic brain injury, they go into cerebral edema after going on ECMO. And at least I can recollect one patient on ECPR. Though we were able to run the circuits, but because of cerebral edema, he phoned and died. And so whenever we think of ECMO, so that's the reason we say when you think of ECMO, think about it before end organ damage happens. In general, in neonates, what we tend to do is do a neurosonogram before going on ECMO, if feasible, to rule out intracranial bleed. If there's intracranial bleed, then we generally don't advise for it. And if somebody has developed intracranial bleed on ECMO, then we do serial head ultrasound maybe twice in a day or at least daily once to make sure the bleeding is not getting worse. So if the bleeding getting worse, then that may be the point you need to come off ECMO. We had one of our baby recurrent aspiration had some bleed on day 6 of ECMO, but fortunately that bleeding didn't increase. We kept on watching very closely and we tried to correct all the coagulation within, maintain the platelets more than 1 lakh and trying to maintain lower ACTs. Other complications are cardiovascular, cardiac stunt, which we discussed yesterday on veno-arterial mode of ECMO. And that is the reason generally if the primary reason is not the heart, if going on ECMO, consider veno-venous ECMO, because veno-arterial ECMO is increased afterload to the heart. So even normal heart can give up if the afterload is increased. But so that itself can cause problems with the left atrial dilatation, pulmonary edema. So you need to have measures how to deal with those things. So generally what we tend to do is if we go on veno-arterial ECMO, so we do the serial echoes to make sure we're not developing into the left atrial hypertension or myocardial stunt. So generally tend to give some afterload reduction medicines like milrinone, or some amount of adrenaline, maybe around 0.02 to 0.05 micrograms per kilo per minute for inotropic effect, not vasoconstrictor, but just for the inotropic effect, so that heart can eject. So if you have all these medical measures fails, then you need to think about other intervention measures where balloon nephrostomy or left atrial vent, or sometimes surgical vent to decompress the left side of the heart. Other things we've seen is hypertension. When the patient goes on ECMO, so usually seen in the veno-venous mode. It can be seen in any mode of ECMO. Generally, veno-venous mode is more common. The pathophysiology is not entirely known, but we can treat it with any vasodilators, and it's going to be transient until the patient gets used to it, and those things can be dealt. But you need to be aware of these things to manage this. Respiratory complications, mainly and if you have veno-arterial ECMO. And yesterday we had a discussion about if you have a veno-arterial ECMO, there is very little blood going to the lungs and very sluggish blood flow maybe, so that might cause thrombosis or maybe ischemia to the lung tissue itself because of very low flow in the lungs. So you need to be aware of those things. That's another reason to think about veno-venous mode whenever you can do it. Even if you go on veno-arterial mode, then when the heart recovers, then think about whether you can change it to veno-venous mode. And they can prone for all sort of complications like pneumothorax if you're not careful enough. So these lungs are quite fragile lungs, and even the coughing episodes on the ventilator can cause pneumothorax. So you need to be aware of those things. They're also prone for acute kidney injury, and there can be multiple causes for that, ranging from hypertension, from hypoxemia before going on ECMO, primary illness, sepsis, the toxins, even iatrogenic like antibiotics, aminoglycosides, cholesterol. Those things can cause a nephrotoxicity. In terms of ECMO, because if you go on ECMO, it's a non-pulsatile flow, there's a theoretical risk, but if you maintain the flows good enough, that should be okay. And if you have hemolysis, that also can cause, but most often it's usually the increased volume load and with the background of kidney not able to deal with that much load. So we tend to use ultrafiltration in those situations. So if it is related to surge response, and then that should get better within the next 48 hours. But if it's a fluid overload and if you're not able to maintain the diuresis even with a last 6 furosemide infusion, then think about dialysis. And they can develop all sorts of complications, metabolic abnormalities. One of the things we had was, I can recollect, we had an 18-year-old girl with hematological malignancy and went into full-blown sepsis and cardiogenic shock. So we went on veno-arterial mode of the ECMO. And the moment soon after we went on ECMO and flows were established, she became completely stiff to the point like a rigor mortis. Then we didn't know what to do. And then after some time it could be hypocalcemia. Then we checked the calcium was very low. So while going on ECMO, we gave the stored blood, and that contained citrate, and that decreased the calcium levels even further. So that can happen. And similarly, hyperkalemia if you're using old blood. So what we tend to do is we tend to request a fresh blood if possible. Otherwise, send a blood gas and the priming blood which you're using for the circuit. Then that will give you some idea how much potassium is there in the blood. If you're going a veno-arterial ECMO, especially using the femoral artery, leg ischemia is distal limb ischemia is the issue. So you need to be aware of these things and tackle with these things. One of the experience, we tried to use it initially, same thing with a near lock, one patient, but that didn't really help for me to maintain the flows distally. So what we do using now is using Y connector and use a 8 to 10 French aortic cannula for the distal limb. So that is maintaining the circulation. So then you have to devise your own this thing, how it works out for you. There are instances actually where the patient survived, but you had to amputate the leg. And after some time, patient or family don't remember how these struggles have make the patient alive. What it remains is just a amputated leg and handicapped. So you need to think about those things, aware of those things. Infections already addressed. There is a complication which is given in ELSO registry. Common complications we discussed already. So mechanical complications like anything can happen to the circuit, ranging from oxygenator failure, rupture of the tubing, pump stopping, heat exchanger is not working, there may be clots in the circuit, thinking in the cannula. So all these things, anticipation, and be prepared for these things. And keep a record of what's happening for you. Because it's not like you're doing some procedure in OR for 4 to 6 hours. It's going to be there weeks and for days and days, sometimes weeks, 24/7. So not only you, the team, entire team has to be aware of these things. And especially the nurses who are there at the bedside, middle of the night, who can take care of the patient, they need to be aware of these things, and so that they can alert you. So thrombosis is the commonest. Usually it happens in oxygenator, or you have a connectors in the circuit. So it's unavoidable, but minor clots is usually not a major issue. But if a major clots, that can impair the oxygenator. So one of the things we monitor on the circuit is the measure the pre and post oxygenator pressure gradient. If the pressure gradient is increasing, that means this oxygenator is getting clotted, and they need to be ready with another oxygenator. Don't wait for it to fail completely. And another way to is to post-membrane gases. Generally, it should be more than 300. That means the oxygenator is working. If the oxygen levels are coming down less than 200, that means the oxygenator is failing, then you need to be ready with another oxygenator. So other things Dr. Pranay sir mentioned yesterday, so you're putting the cannulas very close to the heart or into the heart. So if you're not careful enough, there's a chance that you may tear it. That is one of the big vessels of the heart. So you need to be aware of these things and have a backup plan. What are you going to do? How are you going to deal with these complications? If you're going to, it's not just about putting a cannula. What if things go according to the plan? What is the plan B or plan C? So at least making aware, making sure surgeon is there in the vicinity or in the hospital, that might help you to rescue the situations. Or thinking of a cannula. If you're not able to get the good flows, go to the circuit, starting from the cannula and run through the entire circuit and say, well, is there a kink in the cannula? So all these things, any of these things happens, important thing is you need to identify this thing. Patient should come off the circuit. So another thing we say is whenever you have a circuit, at least have some clamps at the bedside. Something goes wrong, at least you can clamp up the circuit and isolate the patient from the circuit and deal with the circuit. But that's going to be an emergency situation. So you need to be ready with going on full ventilation. Maybe I support the heart with inotropes, and somebody deal with the patient, another person deal with the circuit. If you have oxygenator failure, then obviously you need to come off these things. So most of these things, if you anticipate, and then you can deal with all these things. If you have power failure, then have another battery or a hand crank. I think one of the Suresh Kofianis has shared his experience this morning. In the olden days, when he had a problem, he had to hand crank for almost a couple of hours to run the circuit. That was a cardiopulmonary bypass circuit, but it's the same thing which can happen to the ECMO circuit as well. So if air in the circuit, I think all those things you're going to have a hands-on station. So better skip these things and quickly. So actually, accidental decannulation. Another thing, what I've noticed in my experience, and probably Sunil can share, is neck cannulas. They're okay for the first 3 to 4 days. After 5th to 6th day, they become a bit loose and start moving. It may be because of physiotherapy or patient is awake and trying to move. Femoral cannulas generally tend to be a bit more inside and secure compared to the neck cannulas. And there are a couple of incidents where the neck cannulas actually been out. I mean, that is almost like 3 weeks into the ECMO, and the cannula become quite loose, and people are not being aware. Because of bleeding, you put a gauze piece and another gauze piece on top of that. You don't know what's going on underneath, and covered with non-transparent dressing. You don't know what's going on. and suddenly cannula comes out, then you realize blood everywhere. That has happened a couple of times to the once to us and one of my friends. The incident what happened to us was, it is a panic situation, but by then track was found. We put the cannula back again directly into the vein, secure it, but it's not the case all the time. One of our other friends happened was she was ready to come off ECMO, middle of the night cannula came out, and he had to rush to the hospital in the car with risking his own life, high speed. But luckily that patient survived because she was almost ready to come off ECMO. But they ended up giving like lots of blood transfusion, and that luckily patient survived, but with other morbidities like prolongation of ICU stay, ventilation, and all those things. So if it happens, then you need to come off ECMO, apply pressure, and repair the cannula site if possible. But again, be aware, anticipate these things would be better. So at least on a daily round, you need to make sure that cannulas are secure. Make sure whatever the stitches you put, they become loose. And I've seen actually they cut through the skin, however deep you put it. First 2-3 days it's okay. After a few days, skin becomes macerated, and cannulas, even 10 silk, it cuts through the skin. Same thing on ELSO registry, these things. So there's some experience. If anybody has any experience to share, please. Any questions? If you have no questions, then just small announcement. So we're doing a 8th annual conference in the end of October at Hyderabad. So if anybody is interested, let us know, one of us, and we can take your details. It's going to be 4 days. First 2 days is a workshop, so simulation similar to what we're doing here, and followed by the conference where the international speakers have been invited, quite a few international speakers. Thank you. Sorry?